Sorry, I understand it's Wednesday evening and it's finally sunny, so thank you a lot for coming. So again, thank you, Sandra, for the introduction. I'm Naomi. I have just graduated from St George's. I'll be starting my F1 at St George's as well. So if you guys are St George's students and you have any questions about your years going through med or anything to do with F1 stuff, I'll be more than happy to answer them as well. Okay, so today's session is on SBAs and ophthalmology. So ophthalmology is not a very big topic within medical school. You only get 2 or 3 days worth of placement on the whole specialty itself. However, both my PE year and my final year exams, lots of questions. And for those who are George's students, PE year is the penultimate year, so your 4th year of medicine. Okay, so let's get started. The topics that are generally covered today, I'm not 100% sure if I put them all in order because I didn't want to do questions and you knew what was coming up basically. So the topics that we have are acute loss of vision, chronic loss of vision, and acute red eye. Okay, so first SBA, I think there should be a Q&A option coming up. But I'll read it to you guys anyway. So a 63-year-old woman presents to A&E with right-sided vision loss. On examination, there's evidence of an inferior hemianopsia and a pale disc on fundoscopy. Pale disc means generally optic atrophy, so anything that could be affecting the head of the optic nerve. On further history, you note that she is a long-term sufferer of right-sided temporal headaches and jaw claudication. You refer her to ophthalmology, and whilst preparing her notes, you see that she's also a rheumatology outpatient. Which rheumatological condition is this woman most likely to suffer from? Perfect, so well done. I felt like that was quite a hard question, but you've all done really well. So yes, the answer is polymyalgia rheumatica, so well done for those who got it right. Okay, so polymyalgia rheumatica is related to a condition called giant cell arteritis, which is also known as temporal arteritis. It is an ocular emergency. There aren't many, but this is definitely one of them. So on the right, on the picture here, I'm not sure if you guys can see my mouse, but what you can see is basically how you test visual fields within ophthalmology. It's called a Humphrey test, I think. And you can see that the whole the whole underside of the visual field is completely gone. So this would be a hemianopia. So what giant cell arteritis is it's a focal granulomatous inflammation of medium-sized vessels, which most commonly affects the branches of the carotid. The risk factors include being an elderly female, and the clinical presentation is a painless, so it's really important here to remember that it's painless loss of vision, like a curtain coming down. And it's caused and the visual field loss is caused by an arteritic anterior ischemic optic neuropathy. It's a lot of long words, but basically what it means is, Sandra, can you see my mouse moving?
Yes, I can see it.
Yeah, okay, perfect. So what it is here is blockage of the short posterior ciliary artery. So these are the central retinal vessels here that go through the center of the retina. Whereas in arteritic anterior ischemic optic neuropathy, what you have is a blockage of the vessels here, which supply the anterior section of the optic nerve head. Therefore, you can see that it only would affect some kind of segment of the retina, so you only have a half of your visual field loss. Okay, so it's associated with polymyalgia rheumatica. This is a condition where you get pain and stiffness, but not weakness, typically in your shoulder girdle and in your pelvic girdle. So one way to look really slick in your OSCEs is to say, have you got any pain and stiffness in your arms at all? Because this is related to a polymyalgia rheumatica if the patient presents with a visual field loss. The investigations that you do want to do is the slit lamp. Also, your CRP and ESR will be raised. It's an autoimmune condition. You'd want to do an ultrasound Doppler of the temporal artery. And you'd probably do this before you do a temporal artery biopsy, as the results can take a few days. Now, if you can see here, you can see in the right, there's a total disc pallor. So as I said, something that affects the optic nerve head, and flame hemorrhages, which are here. So the management, you treat before investigation. It's an emergency, remember. And this is because 50% lose their vision in the other eye if they're not treated. Management is oral prednisolone or IV methylprednisolone. And you taper slowly over 12 to 18 months. Now, you know that steroids can actually cause stuff like ulcers. You can also have many other side effects, like the cushingoid ones. So you do want to cover with bone and gastric protection as well. Okay. As I said, as Sandra said, any questions, please put them in the Q&A, and I will try to get to them throughout the lecture. But next question. So, John is a 73-year-old diabetic patient who recently suffered with a central retinal vein occlusion. 3 months later, on checkup in ophthalmology outpatients, an abnormality is found on Goldman applanation sonometry. Which complication is John most likely to be suffering from? Cool, so well done. It is glaucoma. 3 of you got that right, so well done for that. Central retinal vein occlusion, you can have several complications. We'll go through them in a second. So you can get a secondary glaucoma from central retinal vein occlusion, and it's actually called the 90-day disease because it typically happens 3 months afterwards. So it's pretty classic to sort of being a glaucoma of a complication of CRVO. So the way that we actually investigate glaucoma, one of the ways is through Goldman applanation sonometry, which measures your pressure inside your eye. So that's the abnormality that would be found on this kind of measurement. So we're going to speak about CRVO and CRAO now. We're going to speak about glaucoma later. But what CRVO, which is central retinal vein occlusion, is blockade of the central retinal vein. So earlier we spoke about the posterior arteries and vessels. These are the central vessels, and these are what are blocked in central retinal pathologies. So the pathophysiology is venous occlusion, blood flow stagnates, and then you get capillary and venous pressure building up. This causes a retinal hypoxia and damage to the capillary endothelial cells and liberation of VEGF, which is vascular endothelial growth factor. Now, this is the factor that's produced that can increase your ability to produce new blood vessels at the back of the eye, which is always a problem because it can increase pressure and makes they can leak, stuff like that. So the risk factors for CRVO is age and hypertension. And what's interesting, actually, because I'm doing my elective on ophthalmology at the moment, they're a bit concerned that CRVO is actually related to COVID as well, because they've seen a rise in cases in it. So that's being under investigation by the Royal College of Ophthalmologists. The clinical presentation of this is a sudden painless loss of vision and a plus or minus a relevant afferent pupillary defect. So you know how you guys test with your direct and consensual testing. So you may get this one in central retinal vein occlusion, and your investigations will include a fundoscopy. So the management includes an anti-VEGF and laser. So we want to stop the effect of VEGF at the back of the eye, producing these new vessels. Prognosis and complications, you can get a macular edema. Now, any edema at the macula, which is around here, can cause a loss of your central vision. So it's always a bad thing. And you can actually also treat with anti-VEGF, which you do in diabetic retinopathy and things like that. You can also get a glaucoma, which, as I said, is a 90-day disease. Central retinal artery occlusion is different. It's a bit more like a stroke, and that's why it's you actually manage the patient in a stroke clinic. So what it is blockade of the central retinal artery, so around here, and it's usually caused by an embolus from the carotid. So sometimes it can be caused by a cholesterol embolus, and this is called a Hollenquist plaque. So it's basically a stroke, because strokes are defined by the tissue that's being damaged now, not the time. So it used to be defined by if it's over 24 hours and it's a stroke versus a TIA. Risk factors for CRAO is diabetes and hypertension. So basically all the cardiovascular risk factors that can cause a stroke. And in clinical presentation, again, is a painless loss of vision, which is sudden, and you're more likely to get a rapid here. One way of looking extra slick again in your OSCEs is to, after you've done the direct and consensual eye test to check for rapid, is ask if one eye appears brighter than the other when looking at the light. So investigations include fundoscopy and workup in a stroke clinic. Unfortunately, there's no proven treatment for CRAO. What you can do is breathe into a bag. This increases your CO2 in your bloodstream and and causes a vasodilation, which will increase blood flow to the back of the eye, because that's what you want to do. You want to counteract the actions of something that's blocking the blood flow there. You can reduce intraocular pressure by IV acetazolamide or an ocular massage, which is literally just massaging the eye. And you also want to refer to a stroke clinic. Cool. So, next question. Hassan, a 69-year-old male, presents to the GP. Oh, gosh. Complaining of flashes and floaters in his right eye. On examination, his visual field and acuity is normal. On examination, there is no rapid. He denies any pain, and his past medical history has nothing of significance. What is causing his symptoms? And I'm really sorry if you saw the answers there. I was trying to check if I had any questions in the Q&A. Cool. So, well done. It was posterior vitreous detachment. Really sorry that if you saw the answer to that question, but yeah, we'll move on. So, vitreous detachment. So this is detachment of the vitreous kind of jelly that's at the back of the eye. It's normally benign and it can go away. However, we are concerned if it's associated with a retinal detachment, which we'll speak about in a second. So what it is separation of the vitreous membrane from the retina here. So risk factors include age and a myopia. A myopia is a short-sightedness, and what happens in a myopic eye is it's a very, very big eye. Okay, so in short-sightedness, the light, the focal point of the light, so where the light reaches at the back of the eye, doesn't actually reach the retina here. It falls short of the retina here, and that's because it's a bigger eye. Whereas in hypermetropia, which is long-sightedness, the focal point reaches around here. So rays of light come in and they focus, but they focus here in hypermetropia, and in myopia, they focus here. And in a normal eye, they would obviously focus on the macula here. Okay. So if you have a bigger eye, everything's more stretched out, so you're more likely to get a vitreous detachment. The clinical presentation is it occurs over hours to days. What you see is flashes of light, and this is due to mechanical stimulation of the photoreceptors. So imagine the vitreous jelly is coming off of the back here of the retina, and it's just stimulating the back of the retina because obviously it is part of the neurological system, and it causes lots of flashes of lights. You get floaters because you have because the pathway of the light is being affected now by the vitreous or condensing here. And you can also get cobwebs across the vision, which is the vitreous forming. So investigations, what you want to do is referral to ophthalmology within 24 hours to rule out a retinal tear, because retinal tear is an emergency. And the management, it's normally benign if you have a normal vitreous detachment. However, if it's associated with a tear, then you have to have surgery. Cool. So this brings us on to retinal detachment. The reason why the answer to the question wasn't a retinal detachment is because that fundoscope is normal. That fundoscopic image is normal. Whereas you can see here, this is a clear retinal detachment. The retina is pulled away from the back. So there's 3 types of retinal detachment. I'll just go over the definition quickly, sorry. So what it is separation of the neurosensory retina from the retinal pigmented epithelium, which is a layer of the retina, which allows fluid to accumulate behind. There are 3 types. This word, I have gone through my whole ophthalmology elective avoiding pronouncing this word because I don't know how to pronounce it, and I'm going to avoid it now as well. But this is the most common type. It's caused by tears in the posterior, tears caused by posterior vitreous detachment or degenerative retinal changes, so kind of like age. It can also be caused by trauma and a myopia. So again, that stretched, elongated eye in a short-sightedness, the retina can pull away. So fluid from the vitreous accumulates in the subretinal space, so behind here. Okay, so a tractional one is a bit different. It's caused by the vitreal membrane, so this part, pulling away from the underlying retinal pigmented epithelium. This is seen in CRVO. Remember we spoke about CRVO releasing VEGF, so it could be due to lots of vessels being produced at the back there after a retinal vein occlusion. And then you can also have an exudative one, which is caused by damage to retinal pigmented epithelium resulting in fluid accumulation. So the clinical presentation, again, is hours to days, flashes of light due to mechanical stimulation of the retinal photoreceptors, floaters, curtain of blackness, and a relevant afferent pupillary defect. The investigations that you want to do is definitely a fundoscopy. You probably do stuff like OCT, all those kind of things as well. But you definitely want to do fundoscopy to be able to look in the back of the eye. And how you want to manage it is via vitrectomy, so remove all the vitreous. And then what you do is you inject lots of other fluid inside the eye, which is able to then increase the pressure and push the retina against the back of the eye. So it's with a gas injection. One fun fact that I learned the other day is that you can't actually fly, as in a plane, after you've had a gas injection because I think it's the volatility of the gases change with pressure in the air. So your eye can basically burst, which is pretty gross if you're like flying. So you can't fly after you've had the vitrectomy and gas injection. Cool. Again, sorry, just checking the chat. Thanks, Kaz. But no Q&A, so I'll move on. And let me know if I'm going too fast as well. Cool. So next question. Susan is attending glaucoma clinic for a checkup of her primary open-angle glaucoma. She's being prescribed latanoprost, which is a prostaglandin eye drops, but they have failed to control her intraocular pressure. The ophthalmologist is considering prescribing another medication. Susan's past medical history is significant for COPD and hypercholesterolemia. Her current medications include simvastatin and a SAMA. Which glaucoma medication should the ophthalmologist avoid prescribing? So again, 30 seconds. Cool. So people put B mostly. I don't know if you guys can see the results. I think you can. So the answer is actually a beta blocker. So she's got COPD. You don't want to give someone a beta blocker because it can constrict the airways. So beta blocker contraindicated here. Cool. So primary open angle glaucoma. So what it is you have raised intraocular pressure. So over 21 milligrams of mercury with associated visual field changes and or changes to the optic nerve head. Now, the visual field changes that you have are actually, they only present quite late. Therefore, glaucoma is a condition that is screened by opticians. And they look with a fundoscope at the back of the eye and the optic nerve head. And we'll talk about the changes in a second. So the investigations includes a referral to ophthalmology. You'd want to do a slit lamp, which I don't know if you guys have seen, but it's that big contraption that I've only just learned how to use yesterday because it's actually really hard, but it's that big old thing. Goldman applanation tonometry. So what it is it's a device that you can kind of push against the cornea of the eye and test the pressure with. You want to do visual field testing and gonioscopy, which is where you put a kind of lensy thing on the top of the eye and you can have a look at the angle to assess whether it's like open angle or closed angle. So risk factors, this is a really terrible mnemonic that I made up. You can take it or leave it, but MAFIAT, like my Fiat car. So what it is a myopia. Age, family history, intraocular pressure, obviously, African descent, and a thin cornea. Okay, so if you look to the top right of the screen, what you can see here is the visual field defects that you get in glaucoma in sequence. So I don't know how many of you guys are interested in ophthalmology. I did the G-Calder exam, and you have to know all of the different kind of steps of which glaucoma affects your visual field. So here is some of them. What you guys do really need to know for finals or for your fourth year exams is this information here in the bottom right. So in glaucoma, what you have is a large cup to disc ratio. So this is your optic cup here, and this is your disc. And so what happens is you have a massive increase in pressure at the back of the eye, and the cup gets way bigger if you look at the right here, just because everything is pushing against the cup. Here we go. And the neuroretinal rim here becomes thinner. So you can see it's really, really small. Normal ratio of cup to disc is 0.1 to 0.4, whereas if you have a glaucoma, it's more than 0.7. So the cup approaches the same diameter as the disc. What you also get is a vertical elongation. So this cup here will elongate like this. more so than it would to the side. Rim thinning, we spoke about that. And you also get something called vessel bayoneting. So the thinning of the neural rim causes a sharpened rim, and the vessels bend sharply at the edge. So this is a normal optic nerve head. What happens is, if you follow the line of my mouse, the central retinal vessels go over here, and they're meant to go straight down, right? Whereas if you have thinning of the neuroretinal rim, what happens is they come down and they go underneath like that. So you can see it quite clearly here. This is quite a nice picture. So the vessels have come down like that. And this is called vessel bayoneting. I'm just checking if I have any questions. I don't. Cool. So primary open angle glaucoma is different to closed angle glaucoma. Well, I'll explain why in a second. But this picture here I took from the first aid U assembly book. It is so good for all of your med school needs. I really used it throughout. And I think here's a nice picture of like where the vessels are, and it will tell you about how the different medications act on different areas in the eye. I really recommend getting that book just to broaden your kind of understanding, which is obviously really important for learning med. So sorry, I just saw in the chat that someone asked what book it was. It's the First Aid U Assembly book. It's the 2021. I think you can find it online. I don't work for U Assembly. I just really rate the book. Cool. So how the eye gets rid of its pressure is via this mechanism here. So fluid is made by the non-pigmented ciliated epithelium of the ciliary body here. It produces aqueous humor. Now aqueous humor travels up here, goes between the lens and the iris, and then comes around the top of the iris and then gets drained mostly by the trabecular meshwork and some of it by the UV or scleral route. Okay, so in open angle glaucoma, where you have everything stretched out and a massive eye, what happens is the angle here increases. So it's an open angle. So you could have blockage here, which could cause it. So the angle between the iris and the cornea is open, it's big. Whereas in a closed angle glaucoma, what you have is a massive build-up of pressure here, and the angle is closed. So the iris gets pushed up and the lens gets pushed up against the top of the cornea. So it's a closed angle. And in closed angle glaucoma, you typically have way higher pressures than you do in an open angle glaucoma. Cool. Next question. Next section. So this is a table of all the medications, all the common medications used in glaucoma. I'm not going to go through it for the interest of time, but you guys will have access to these slides. I'd also really appreciate if you guys could fill in feedback forms. And if you do so, then I can send you my spreadsheet that I've made of all the kind of ophthalmology medications that you could possibly know. But this is just for open angle glaucoma. The picture here is in reference to sorry guys. So if you see here, this picture is in reference to prostaglandin analogs. So one of the side effects is pigmentation of the iris and the periocular skin pigmentation. One of the side effects is pigmentation. You basically get elongated eyelashes, and the area around just darkens. So you can see really here how it can compare from the right eye to the left eye, which isn't being treated with prostaglandins. I've just been asked to do a quick 5-minute break, so you guys can run to the loo if you want. I don't think we have much of the lecture left, but we'll do a 5-minute break here. So thanks, guys.